Welcome to Chapter 7 of the BCSC Glaucoma series, where we focus on primary open-angle glaucoma. In this section, we'll explore the clinical features, risk factors, diagnostic strategies, and management principles for this common but potentially vision-threatening condition. As we progress, we'll connect key concepts from earlier chapters with the unique aspects of primary open-angle disease, building a complete understanding of how to identify and treat glaucomatous damage in these patients. Primary open-angle glaucoma develops through a combination of structural, vascular, and genetic influences. Age, race, and a positive family history all play important roles, along with ocular characteristics such as central corneal thickness, myopia, and elevated intraocular pressure. However, pressure alone does not tell the full story. Ocular perfusion pressure, which is the difference between blood pressure and intraocular pressure, is another key factor. When this value is low, the risk of optic nerve damage rises, though the relationship between blood pressure and glaucomatous change remains complex. Importantly, open-angle glaucoma can occur across a wide spectrum of intraocular pressures, meaning normal readings do not rule it out. The only proven way to slow or prevent progression is to reduce intraocular pressure, whether through medications, laser therapy, or incisional surgery. In patients with ocular hypertension, early treatment significantly decreases the likelihood of developing glaucoma over time. Primary open-angle glaucoma is a chronic, slowly progressive optic neuropathy characterized by optic nerve damage and corresponding visual field loss. The major risk factors include elevated intraocular pressure, increasing age, certain racial backgrounds, thinner central corneas, myopia, and a family history of the disease. Additional contributors can further increase risk, such as low corneal hysteresis, reduced ocular perfusion pressure, low cerebrospinal fluid pressure, metabolic abnormalities within axons or ganglion cells, and structural weaknesses in the lamina cribrosus extracellular matrix. The pathogenesis is multifactorial, involving a complex interplay of mechanical, vascular, and cellular processes that are still not completely understood. While primary open-angle disease has no clear external cause, secondary open-angle glaucoma arises from identifiable conditions such as pigment dispersion or pseudoexfoliation syndrome. Now that we've covered the definition and risk factors, let's look at the clinical features that characterize primary open-angle glaucoma. This disease typically begins insidiously, progressing slowly and without pain. It usually affects both eyes, although the severity can be asymmetric between them. Because the early changes occur in the peripheral vision, many patients remain completely unaware of the condition until later stages, when central vision finally becomes compromised. Diagnosis relies on careful evaluation of the optic nerve and retinal nerve fiber layer, combined with visual field testing to detect characteristic patterns of loss. Moving from the general clinical picture to a key diagnostic step, we come to gonioscopy. This examination is essential for confirming that the anterior chamber angle is indeed open, a requirement before diagnosing primary open-angle glaucoma. Gonioscopy should be performed on all patients undergoing evaluation for glaucoma. It is not a one-time test. Repeat examinations are warranted in several scenarios, including ongoing monitoring of established open-angle disease, suspected progressive narrowing of the angle due to lens changes or hyperopia, and in cases with a shallow anterior chamber, strong miotic use, or following procedures such as ALT or LPI, particularly if intraocular pressure rises. Building on the importance of confirming an open angle, we next focus on how the optic nerve and visual fields are assessed in primary open-angle glaucoma. Diagnosis is grounded in the combined interpretation of optic disc appearance and visual field test results. Because this is a progressive disease, periodic evaluations are essential for monitoring and adjusting management. Tools such as stereophotography and computerized imaging allow for the detection of subtle structural changes over time. In most cases, the pattern of visual field loss corresponds closely with optic nerve damage. However, when there is a mismatch between the nerve's appearance and the visual field findings, further investigation is needed to rule out alternative diagnoses or concurrent pathology. As we continue, it's important to recognize situations where the presentation does not fit the typical pattern of primary open-angle glaucoma. Atypical findings should prompt us to consider alternative diagnoses. These include cases where the disease is strictly unilateral, where there is a marked reduction in central vision, or the presence of color vision defects. Unusually young patients, those with a relative afferent pupillary defect, neuroretinal rim pallor, or visual field loss patterns that do not match the optic nerve appearance all fall into this category. Possible underlying causes range from compressive lesions and carotid artery insufficiency to anemia, syphilis, vitamin deficiencies, giant cell arteritis, vasculitis, or toxic exposures. The workup in these cases should be thorough, including a medical and neurologic evaluation, non-invasive carotid studies such as Doppler imaging, and MRI or CT of the anterior visual pathway or optic chiasm when optic nerve pallor or neurologic visual field defects are present. Shifting now to one of the most well-recognized risk factors for primary open-angle glaucoma, we focus on intraocular pressure. Elevated IOP is a strong predictor for disease development, but it is not required for diagnosis. In European-derived populations, the mean IOP is about 15.5 millimeters of mercury, with a standard deviation of 2.6, though this varies among racial and ethnic groups. The traditional definition of abnormal, anything above 21 millimeters of mercury, is now seen as limited, since many patients with glaucoma have pressures below this level. The overall distribution of IOP is skewed toward higher values, but there is significant overlap between glaucomatous and non-glaucomatous eyes. In fact, 30 to 50% of patients with primary open-angle glaucoma present with pressures under 22 millimeters of mercury. Still, a higher pressure anywhere within the range increases risk. Intraocular pressure also fluctuates over a 24-hour period, meaning office measurements may miss true peaks, and large diurnal fluctuations themselves have been identified in some studies as independent risk factors. Let's turn to central corneal thickness and how it impacts IOP. In previous chapters, we have discussed how CCT directly impacts how we interpret measured IOP values. A thicker cornea can cause us to overestimate true intraocular pressure, while a thinner cornea may lead to underestimation. For adults, the average central corneal thickness is roughly 525 to 550 micrometers, though this varies across racial and ethnic groups. Notably, the mean CCT is generally lower in individuals of African ancestry compared with those of European ancestry, a difference that can have significant implications for glaucoma risk assessment and monitoring. Following our discussion on how corneal thickness can influence IOP readings, it's also important to understand why cases of high-tension glaucoma may go undetected. One reason is primary open-angle glaucoma with significant diurnal pressure fluctuations, where a single office reading may miss the true peak. Intermittent IOP elevation can also occur from asymptomatic angle closure, glaucomatous cyclic crisis, or various forms of secondary glaucoma, such as pigmentary, pseudoexfoliation, or uveitis-associated types. In some eyes, previously elevated IOP may normalize. This can happen after conditions like corticosteroid-induced glaucoma, uveitis, pigment dispersion, or hyphema have resolved. Certain medications, such as systemic beta blockers, may lower IOP enough to mask the diagnosis. Finally, inaccurate pressure measurements can arise from thin central corneas, reduced scleral rigidity, improperly calibrated devices, or poor examiner technique. Another important risk factor for primary open-angle glaucoma is older age. The prevalence of the disease rises steadily as patients get older. In the Baltimore Eye Survey, more than 11% of individuals of African descent over the age of 80 were found to have glaucoma. Data from the CIGTS trial showed that visual field defects were 7 times more likely to progress in patients aged 60 and above compared with those under 40. The OHTS study also confirmed that the risk of progression increases with age by about 43% per decade in univariate analysis and 22% per decade when other variables are accounted for. This makes older age an independent risk factor, both for the development of glaucoma and for the rate at which it advances. Race and ethnicity also play a significant role in the risk for primary open-angle glaucoma. In the United States, prevalence is about 3 to 4 times higher in individuals of African descent or Hispanic ethnicity compared with European-derived populations. Blindness from glaucoma is at least 4 times more common in Black individuals compared with white individuals. Black patients are often diagnosed at a younger age and tend to present with more advanced disease. In the OHTS trial, univariate analysis showed a 59% higher risk of POAG in Black patients with ocular hypertension defined as intraocular pressure of 24 millimeters of mercury or higher compared with white patients. However, this association was not statistically significant in multivariate analysis once adjustments were made for central corneal thickness and baseline cup-to-disc ratio. On average, Black patients tend to have thinner corneas and larger baseline vertical cup-to-disc ratios, factors that may contribute to the increased burden of disease. Another key risk factor for primary open-angle glaucoma is a thin central cornea, often accompanied by low corneal hysteresis. Thin corneas are linked both to greater risk of disease development in ocular hypertension and to faster progression in established glaucoma, particularly when baseline pressures are high. This association is not explained solely by the underestimation of IOP that occurs with Goldmann applanation tonometry, and current evidence does not support adjusting IOP values mathematically based on corneal thickness. Instead, thin corneas may represent a broader biomarker of structural susceptibility to optic nerve damage. On average, Black patients have thinner corneas than white patients, which may partly account for the higher prevalence and severity seen in this group. Low corneal hysteresis, reflecting reduced biomechanical damping capacity of the cornea, is also associated with a higher risk of glaucoma progression. Family history is another well-established risk factor for primary open-angle glaucoma. Data from the Baltimore Eye Survey show that individuals with an affected sibling have about a 3.7 times higher relative risk of developing the disease. This increased familial risk is likely driven by shared genetic factors, though the inheritance pattern is usually complex. Simple Mendelian inheritance is uncommon, meaning that glaucoma typically results from the interaction of multiple genes along with environmental influences. Myopia is another factor that has been linked to primary open-angle glaucoma in several population studies. The Beaver Dam Eye study found that even mild myopia greater than 1 diopter was associated with increased glaucoma risk. The Rotterdam study reported a hazard ratio of 2.3 for developing glaucoma over 10 years in patients with more than 4 diopters of myopia. In the Beijing Eye study, high myopia exceeding 6 diopters carried an odds ratio of 8 compared with emmetropic eyes, and the Blue Mountain study found a 3.3 odds ratio for myopia over 3 diopters. However, the OHTS did not find a clear association between myopia and the rate of glaucoma progression. Diagnostically, myopic eyes present unique challenges. Tilted optic discs, posterior staphylomas, and optical minification can complicate optic nerve evaluation. Myopia-related retinal degeneration can mimic glaucomatous visual field defects, and highly myopic patients may have greater difficulty performing reliable visual field testing. Now, we will shift to systemic associations with primary open-angle glaucoma. Diabetes mellitus is a systemic condition that has been studied in relation to primary open-angle glaucoma, though the evidence is mixed. Some large population studies, such as the Beaver Dam, Blue Mountains, and Los Angeles Latino Eye studies, have found an increased risk of open-angle glaucoma among diabetics. Other studies, including the Framingham, Baltimore Eye, Barbados Eye, and a revised Rotterdam analysis, have found no significant association. In the OHTS, the link between diabetes and glaucoma varied depending on the analysis method used, with some results even suggesting a reduced risk in diabetic patients. One possible explanation is that OHTS excluded participants with diabetic retinopathy, which may have skewed the findings and reduced the apparent risk. Hypertension is another systemic factor that has been investigated for its relationship to primary open-angle glaucoma. In the Baltimore Eye Survey, systemic hypertension in individuals under 65 was associated with a lower risk of glaucoma, possibly due to improved optic nerve perfusion. However, in older patients, the risk was higher, which may reflect the damaging effects of long-standing hypertension on the microcirculation of the optic nerve. The Barbados Eye study found that hypertension was associated with a relative risk of less than 1 for glaucoma across all age groups, even in those 70 years and older, suggesting that the relationship between blood pressure and glaucoma risk is complex and may vary depending on age and vascular health. Now we turn to lower ocular perfusion pressure, or OPP, which is a major vascular risk factor for glaucoma. OPP is calculated as the diastolic blood pressure plus 1/3 of the systolic blood pressure, minus the intraocular pressure. Low OPP has been strongly associated with both the development and progression of glaucoma. In the Baltimore Eye Survey, individuals in the lowest OPP category had a 6-fold higher prevalence of the disease. The EMGT study found that low systolic perfusion pressure, defined as 160 millimeters of mercury or less, carried a hazard ratio of 1.42 for progression. The mechanism is thought to involve reduced optic nerve perfusion, potentially worsened by impaired autoregulation of blood flow. Clinically, overtreatment of systemic hypertension can inadvertently lower OPP and, in some cases, worsen glaucoma, which is worth considering when managing patients whose disease progresses despite seemingly adequate pressure control. In addition to the major systemic associations we've discussed, several other conditions have been reported in some studies as possible glaucoma risk factors. These include sleep apnea, thyroid disorders, hypercholesterolemia, migraine headaches, low cerebrospinal fluid pressure, and Raynaud's phenomenon. While these associations are intriguing, their significance and whether they represent a true causal relationship remain unclear. More research is needed to determine if these factors directly contribute to glaucoma development or progression, or if they are simply correlated due to shared underlying mechanisms. When considering prognosis in primary open-angle glaucoma, the outlook for most patients is generally favorable, with many retaining useful vision for life. The greatest risk for blindness occurs in those who already have visual field loss at the time of diagnosis. In one single institution study, after 10 years, 7.4% of patients experienced unilateral blindness and 3.4% became bilaterally blind. At 20 years, these numbers rose to 13.5% for unilateral and 4.3% for bilateral blindness. These statistics highlight the importance of early detection and intervention to preserve vision. In primary open-angle glaucoma, the mainstay of therapy remains lowering intraocular pressure through topical medications, laser treatments, or incisional surgery. These interventions significantly reduce the risk of disease progression. Beyond pressure control, vision rehabilitation plays a critical role for patients who already have meaningful visual impairment. Referral is recommended for those with visual acuity worse than 20/40, severe visual field loss, or reduced contrast sensitivity. Rehabilitation strategies include optimizing lighting, enhancing contrast, and minimizing glare. Patients may also benefit from adaptations for daily living, orientation and mobility training, and vision substitution aids such as talking books or specialized watches. Together, these measures help preserve functional independence and quality of life. Shifting now to the concept of the glaucoma suspect. This term applies to an individual who has one or more findings that raise concern for possible glaucoma, but do not yet meet the full diagnostic criteria. This could include a suspicious optic nerve or nerve fiber layer appearance without a corresponding visual field defect, a visual field defect suggestive of glaucoma without a matching optic nerve abnormality, a first-degree family history of glaucoma, or elevated intraocular pressure without evidence of optic nerve damage. Management focuses on periodic monitoring of the optic nerve, retinal nerve fiber layer, and visual fields. Advanced perimetry techniques like frequency doubling technology, short wavelength automated perimetry, or pattern electroretinography have been proposed but are not strongly evidence-based for routine use. Treatment is initiated if optic nerve damage becomes evident. In uncertain cases, careful observation is often the best approach to confirm whether changes are truly glaucomatous, as elevated pressure combined with structural or functional changes not clearly attributable to glaucoma can make diagnosis challenging. Now let's shift our focus on ocular hypertension, which refers to an intraocular pressure greater than about 21 millimeters of mercury without detectable abnormalities of the optic nerve, retinal nerve fiber layer, or visual field. Its prevalence is estimated to be up to 8 times higher than that of primary open-angle glaucoma. While a higher baseline IOP increases the risk of developing glaucoma, the majority of individuals with elevated pressure will never go on to develop the disease. Differentiating ocular hypertension from early glaucoma requires careful and repeated evaluation of the optic nerve, RNFL, and visual fields. There is no universal agreement on whether to treat elevated pressure in the absence of early damage. The best approach is to assess each patient's full risk profile and selectively treat those believed to be at the greatest risk for progression to glaucoma. The Ocular Hypertension Treatment Study, or OHT, enrolled patients aged 40 to 80 years with intraocular pressures between 24 and 32 millimeters of mercury, randomizing them to observation or topical hypertensive medications. At 5 years, progression to glaucoma occurred in 4.4% of the treatment group compared to 9.5% of the observation group. Notably, most untreated patients did not progress, though the rate was still higher without treatment. The study found that each 1 millimeter of mercury above the mean IOP increased risk by 10%, and each 0.1 increase in vertical cup-to-disc ratio increased risk by 32%. Major risk factors included older age, higher baseline IOP, thinner corneas, larger cup-to-disc ratios, and higher pattern standard deviation on perimetry. Black race was associated with a greater progression risk, likely due in part to thinner corneas and larger cup-to-disc ratios. Family history was not significant in this study, possibly due to underreporting, and no significant associations were found for myopia, diabetes, migraine, or extremes of blood pressure. Lowering intraocular pressure has been shown in the Ocular Hypertension Treatment Study to reduce the risk of glaucoma progression, although much of the progression measured in the trial was incremental structural or functional change that likely would not cause noticeable vision loss. For low-risk patients, delaying treatment is reasonable and does not appear to worsen long-term outcomes. At 13-year follow-up, glaucoma developed in 22% of the observation group, compared to 16% in the treatment group, with 71% of participants still in the study. When deciding on treatment, clinicians should balance the risk of conversion against potential side effects, costs, patient preferences, age, life expectancy, and any baseline optic nerve damage. Risk prediction tools from OHTS and the European Glaucoma Prevention Study can help guide decisions, especially in patients with high-risk features such as older age, higher IOP, thinner corneas, larger cup-to-disc ratios, and higher pattern standard deviation on perimetry. This slide highlights the relationship between retinal vein occlusion and glaucoma. Both glaucoma and ocular hypertension are associated with an increased risk of central retinal vein occlusion, or CRVO. Because of this link, in patients who have already experienced CRVO or hemicentral RVO, it is reasonable to consider treating elevated intraocular pressure to help reduce the risk of a similar event occurring in the fellow eye. Now we move on to the concept of normal tension glaucoma, or NTG. This diagnosis raises the question of whether it is truly a distinct disease or simply primary open-angle glaucoma, occurring in patients with normal intraocular pressure. Importantly, glaucoma can develop at any IOP level within the population range, making IOP a continuous, not binary risk factor. This means that the normal versus abnormal cutoff is somewhat arbitrary. Because of this, many experts suggest retiring the terms normal tension and low tension glaucoma altogether. Next, let's look at the risk factors and clinical features of normal tension glaucoma. Unlike high tension glaucoma, elevated intraocular pressure is just one of many potential risk factors here. In fact, certain populations, such as Japanese patients, have a higher proportion of open-angle glaucoma cases with IOP in the average range. This suggests that other mechanisms are at play. Local vascular factors may contribute, though evidence is inconsistent. These can include migraine, Raynaud phenomenon, ischemic vascular disease, autoimmune disorders, sleep apnea, systemic hypotension, and various coagulopathies. NTG tends to be bilateral but asymmetric, with worse damage often in the eye with the higher IOP. Lastly, optic disc hemorrhages appear to be more common in NTG than in high-tension primary open-angle glaucoma, which can be an important clinical clue. Now, moving on to the visual field characteristics in normal tension glaucoma. Compared to high-tension primary open-angle glaucoma, NTG often presents with visual field defects that are more focal, deeper, and closer to fixation, especially in the early stages. A dense paracentral scotoma near fixation is not uncommon. Some of these observed differences may be due to detection bias, as patients with early central visual symptoms are more likely to notice problems and seek care sooner. Importantly, there are no consistent optic nerve or visual field features that can reliably distinguish NTG from high-tension POAG in all patients. Next, we turn to the differential diagnosis for normal tension glaucoma. NTG can either mimic or be mimicked by a variety of other optic neuropathies, making accurate diagnosis essential to guide proper management. Conditions to keep in mind include congenital anomalies such as coloboma, optic nerve pit, and myopic discs, physiologic cupping from a large scleral canal, optic nerve drusen, compressive optic nerve or chiaspal lesions, anterior ischemic optic neuropathy, AION, posterior ischemic optic neuropathy, PION, and toxic or nutritional optic neuropathies, such as those caused by methanol exposure or vitamin B12 deficiency. Next, we'll cover hidden intraocular pressure elevations in normal tension glaucoma. A normal IOP recorded during office hours may mask higher pressures occurring outside of clinic times. Diurnal IOP measurements can reveal peak pressures and fluctuations, though they still miss nocturnal changes. Elevated IOP may also be masked by systemic medications, particularly beta blockers. In some cases, patients with apparent NTG may have falsely low IOP readings due to altered corneosclerobiomechanics, such as a thin central cornea. Similarly, post-refractive surgery corneal thinning can lead to an underestimation of the true IOP. When evaluating patients with normal tension glaucoma, the overall assessment is similar to other open-angle glaucoma cases. It's important to review the patient's medical history for conditions that could mimic NTG optic nerve or visual field findings. These include significant systemic hemorrhage associated with low blood pressure, myocardial infarction, and episodes of shock. For this final slide on prognosis and therapy in normal tension glaucoma, we start by noting that the initial treatment aim is about a 30% reduction in intraocular pressure from baseline levels. Once this goal is achieved, patients transition into routine follow-up visits, during which their individualized target pressure can be adjusted as needed. These adjustments are guided by factors such as the severity of optic nerve and visual field damage, the risks associated with ongoing therapy, any comorbid conditions, and the patient's life expectancy. Over time, the target pressure is reassessed to ensure that visual function is preserved. The collaborative normal tension glaucoma study found that reducing intraocular pressure by 30% lowered the 5-year risk of visual field progression from 35% to 12%, with the benefit becoming clearer after accounting for cataract effects, which were more frequent in the treated group. Treatment is generally advised unless the optic neuropathy is stable, though about half of untreated patients did not experience progression. Disease worsening is influenced by factors beyond intraocular pressure, and while progression is often slow, it can vary between individuals. Notably, patients with a history of optic disc hemorrhage tend to have a lower benefit from treatment. Management of normal tension glaucoma is generally similar to other open-angle glaucomas, but caution is advised when using beta blockers due to the potential risk of lowering ocular perfusion pressure. The low-pressure glaucoma treatment study found a high progression rate with timolol, though significant follow-up loss limited conclusions. In the early manifest glaucoma trial, bataxolol combined with ALT had minimal IOP lowering effect in eyes with a baseline pressure of 15 millimeters of mercury or less. Patients with low baseline pressures who still show progression may require incisional surgery or non-beta blocker medications. Ultimately, treatment should be tailored to the patient's specific risk factors and disease course. Thank you all for the attention. Take time to review the content, then go over the questions we have provided for this chapter. As always, we'll see you in the next one.